If you have a misfolded protein, amyloid protein, that leads to Alzheimer's in most cases down the road, this can be picked up by doing this blood test.
When we were talking about the ApoE4, I think we do, and would you agree, have a choice in whether that leads to dementia at this point in the game, regardless of our genotype?
Yeah, the data from Dr. Bredesen is looking very promising.
If we have ApoE4 or ApoE44, if we're hetero or homozygous, what's the frequency that we're going to be looking at this? What age do we start at?
There are earlier dementias such as presenile, but for somebody who's cognitively normal and has ApoE44, I would start at 50 personally.
Hi, listeners. New Frontiers in Functional Medicine has been going strong since 2015. With almost 200 episodes and over 2 million downloads, my goal is to bring you the best minds in functional medicine, epigenetics, and longevity. I want actionable insights for the clinician and non-clinician alike. You can access episode transcripts, summaries, research citations, and more over at drkarafitzgerald.com, where you can also find information about our clinic and sign up for the e-newsletter as well. Thanks for supporting this podcast with your likes and your honest reviews, by sharing this with your colleagues, with your family and friends. Thank you also to our sponsors. These are companies that I trust, that we vet carefully, that we use in clinic practice, and that I use personally. Thanks to our diamond level sponsors. For over 40 years, the foundation of biotics research has been innovation and quality. Their goals remain unchanged: innovative ideas, carefully researched concepts, and product development with advanced analytical and manufacturing techniques. Biotics nutritional products are of superior quality and effectiveness. They are available exclusively to the healthcare provider. Find them at bioticsresearch.com. Precision Analytical, creator of the Dutch test, is launching a new educational program this January. They are offering evidence-based training on key topics like hormone metabolism, interpreting Dutch test results, and therapeutic strategies, including hormone replacement therapy, all aimed at improving patient outcomes. Become a registered provider to gain access to an expansive education hub with ongoing content, including webinars and case studies. Visit dutchtest.com/courses to get started and grow your practice. Thanks to our gold level sponsors. Timeline, fueling cellular energy for a lifetime of healthy aging. Find them at timeline.com. Vibrant Wellness, transformative lab tests for wellness. Find them at vibrant-wellness.com.
Hi, everybody. Welcome to New Frontiers in Functional Medicine, where we are interviewing the best minds in functional medicine. And of course, today is no exception. If you're with us on YouTube, you can see that I am sitting next to Dr. Hans Frykman. Let me give you his background, and we will jump right into what will be one of really the most important podcasts perhaps of all time on my show. Dr. Frykman is CEO and Medical Director at BC Neuroimmunology Lab and Neurocode Labs. BC Neuroimmunology Lab has a 35-year history of developing highly specific clinical neuroimmunology testing to the North American marketplace. The lab is a tech leader and is academically collaborating with several leading centers in Europe and the US, and will actually be sure to talk about some of the research they're publishing. Neurocode Labs is Canada's first and only clinical whole exome sequencing facility. Dr. Frykman is Clinical Assistant Professor of Medicine at the University of British Columbia. In his background, he received his postgraduate medical training at Karolinska University Hospital, Mayo Clinic, University of Minnesota, Memorial Sloan Kettering, and University of British Columbia. He's got his medical degree from Karolinska Institute, bioorganic chemistry from the Royal Institute of Technology in Stockholm, and an MSc in chemical engineering from Chalmers University. You went to school for a long time, Dr. Frykman.
Yeah, haven't we all as physicians? But it's just lots of learning. But I think that thanks so much for having me on, Kara. I really appreciate that, and also thanks for the introduction. I just wanted to point out that I am the Chief Scientific Officer of Neurocode Labs, which is located in Bellingham, Washington. very beautiful spot. Everybody told us that we're not supposed to start any high-tech company in a small city like Bellingham, and not in Washington. We should be in California and close to San Francisco and such. But we are trying to prove them wrong, and I think so far so good. So
Awesome. Yeah, yeah, it is. It's a beautiful, beautiful part of the world. So, the reason that I reached out to you, and we've had a couple of great conversations. You taught us on our clinical rounds, is that you guys, your team, has developed, three proteins. You guys have worked really hard on developing the assays around p-tau 217. GFAP, which is glial fibrillary acidic protein, and neurofilament light. So you've been developing the technology that is incredibly sensitive, and we're going to be spending our time talking about why we need to be thinking about these as clinicians. There's also plenty of savvy regular folks listening to this who will be very interested in it. So talk to me about maybe just an overview of these proteins and how you got interested in them, and then we're going to move through all three of them, and we'll start with p-tau 217.
yeah, no, that's good. Thank you. Yeah, so these are proteins that we can measure in blood. They're particularly p-tau 217 is very, very low abundance protein that we measure in extremely small quantities, and we have to have very specialized equipment to do that. And it is rather difficult. But the other proteins as well, the Nf-L and the GFAP proteins are both quite low abundance as well, and we also use specialized equipment there. The utility of these proteins is that they are the p-tau 217 is a very, very accurate protein reflecting amyloid status of the brain, meaning that if you have a misfolded protein, amyloid protein, that leads to Alzheimer's in most cases down the road, then this can be picked up by doing this blood test. And then when it comes to NFL and GFAP, NFL measures something more related to really severe damage to the brain. For example, if you go with Jeff Bezos or Elon Musk's rockets out in space, you damage your brain quite a bit. And for those people that come back to Earth, we can measure quite a bit of increase in NFL because their brains are now damaged. That's the reason why astronauts are only allowed to go on one trip. Humans are not made to go in space, unfortunately.
Well, listen, since you took that little bit of a left turn, it's really interesting. I mean, how long is it? How long do you see NFL elevated?
Mm-hmm. Yeah, it doesn't go back to baseline because the brain is actually permanently damaged, and most of the astronauts, including people that worked in the space station, etc., they have problems throughout life afterwards. It's quite a big sacrifice. We should thank them for that, but it's something that people don't really know. But anyway, let's get back to the main. And so NFL is kind of a non-specific protein that we can measure any kind of nerve damage, also in the periphery, but also in the brain. And then GFAP, the last protein, is perhaps one of the best proteins to measure all kind of dementia, so not only Alzheimer's, but other types of dementia, and can be found very early. There are some studies that indicate that, although it's early work still. The other utility is that GFAP may also reflect inflammation in the brain. And we have had, for example, COVID or other such viruses and
Lyme, neuroborreliosis.
Yeah, exactly. Other microorganisms, other inflammatory chemicals as well, and mold, etc., can increase then GFAP. So this is something that is very useful to measure from that perspective. Definitely, we don't want to have elevated GFAP for a long time, although it can happen occasionally that we have a spike. But the three proteins then in combination makes a very comprehensive view of the brain at any given time. Then if you measure them longitudinally, then you can follow what's going on in your brain. So they stay kind of the same for any individual person over time, although they may rise a little bit when it comes to, for example, p-tau217. It's a very slow rise, but if something starts changing in the brain, then we will have a spike up, and that will reflect something that is more sinister going on.
So these can capture a wide variety of conditions, of neuroinflammatory conditions, triggered by, many different causes, from injury, from traumatic brain injury to,
Correct,
the
yeah.
pathogenesis of Alzheimer. Even I was actually reading about in autism in some cases, we might see a rise in GFAP. So it's, there's quite a bit of utility.
Right. So the GFAP and Nf-L are unspecific. There are quite a broad range of different conditions that they can rise, and so it kind of gives us an insight into that we should investigate further. p-tau217 is highly specific just for amyloid, really, and very, very few other, false positive or false signals for other things.
So I've got a lot of questions, like, when do we get them? But before you get into that, let's just talk about, like, p-tau217. How early might we see this, close to or falling out of the reference range?
That's a good question. So today's assays, we are probably able to start seeing the signal with fair confidence already at the MCI stage. So that's the pre-stage of mild dementia. So minimal cognitive impairment is called, and that's when you're, you have some history of forgetting things, and you have some history of not being able to execute things, but you're still fairly functional. You live independently and so forth. When that is a very good stage to be able to catch the disease, but obviously we'd like to do it even earlier. And so there will be second generation tests that we will launch actually this year that will be able to look even at people that are cognitively unimpaired. So cognitively unimpaired meaning that they're completely normal. We can then differentiate with high certainty people that are cognitively unimpaired from those that are also cognitively unimpaired, but one have amyloid and one do not. And obviously the ones with amyloid, the question becomes, are they all going to develop Alzheimer's? That's something we do not know. But if they have genetic expression of ApoE4, even one ApoE4 gene, then they are bound to develop Alzheimer's. If they don't have any ApoE4, they just have ApoE33 or other combinations, then we are perhaps looking at them more as a red flag. We're not, certain if they're going to develop Alzheimer's or not at this time.
I want to circle back and talk more about the ApoE4. There's definitely people listening to this who have it, and I want to get a little bit more clarification on that. But before I do that, what is this new assay? Is it just a more sensitive p-tau217?
Yeah, it's 10 times better than the previous ones. So we are the only lab in the US that have a very sensitive assay that can distinguish minimal cognitive impairment from those that do not have it with amyloid pathology. So if you go to the legacy labs such as LabCorp, Quest, or Mayo, they use an assay that is only useful in mild dementia. Our assay and their assay is the same in mild dementia, but our assay and their assay is different when it comes to minimal cognitive impairment.
So they just have to be further along the pathology for
if they're
for
further
LabCorp
along the
Quest to pick them up.
pathology, any assay works. But if they are at the MCI stage, which is the best stage that we can catch at this time, then they should use our assay. If they want to even go further and go, this detect this already when they're cognitively unimpaired, meaning that they were completely normal, they have no idea that what is going on in the brain, then our new assay is going to be most appropriate assay. So essentially, we can look at 3 different types of assays, and for different times in the pathology, if that makes sense.
Sure, no, it makes total sense. But in the arena of prevention, where many of us in functional medicine sit, we're going to be wanting to use the current assay and then the more sensitive assay when it's available.
Yeah.
I think most of us will just jump to the more sensitive assay.
Correct.
That makes a lot of sense.
Yeah.
So I want to push back. Go ahead. You were going to say something.
Yeah, I mean, it's important that you then help the patients to understand what is their risk to develop things, and also help them to feel comfortable with the plan how to avoid then getting Alzheimer's, and that is, I think, possible now to circumvent it. So.
Yes, well, I want to underline that and exclamation point that, because when we were talking about the ApoE4 folks, I think we do, and would you agree, have a choice in whether that leads to dementia at this point in the game? I mean, I think people are really putting some evidence behind the fact that we have a choice in, outcomes, regardless of our genotype.
Yeah, the data from Dr. Bredesen is looking very promising that he shared with me. So the people that has followed his protocol that are ApoE44 have not developed dementia at even at the old age, which in normal cases almost 100% that develop dementia by the age of 70 or 75.
It's extraordinary.
So it's just extraordinary. So it's backwards. You can prove it backwards. Essentially, if you have ApoE44, you're supposed to develop dementia at a certain age. If you don't do it, then it's remarkable.
It's absolutely remarkable. Yeah, and so this is Dale Bredesen. Folks, we'll just link in the show notes to anything that we're referencing here, papers or otherwise, and my conversations with Dr. Bredesen we'll make available to you as well. The Bredesen protocol, if you're not familiar with it, is just one of the most extraordinary programs out there. But there's also so just on this track, you're involved in some drug trials. People are using your assays as well. Are there anything promising in that arena?
Yeah, I think there are certain drugs already now coming to market in many countries. United States was, I believe, the first country to launch lecanemab and donanemab from Eisai and Eli Lilly. So those drugs in some patients work very well with even reversing cognitive decline. So they have gotten a stamp that they're not fantastic drugs, and that may be true in that they don't help everyone. But at the same time, there are people, and I'm getting feedback constantly now that there are people that are completely kind of reversing. So it depends, is your belief in the methodologies of Dr. Bredesen, or is your belief in hardcore pharmaceutical treatments, or both, or either. You're starting to have choices here, is what my point is. And
do we know who is more likely to respond to those?
Yeah, so I think the ones that have pure amyloid pathology which we measure then with our assay, those are the ones that are the more likely to get benefit and earlier on in the disease process. It takes time for these drugs to work. And then, however, those that don't have ApoE44 are probably better off using these drugs than the ones that have ApoE44, because the drugs can be dangerous for that group with brain bleed that leads to ARIA, which is a brain swelling, and then neurodegeneration, actually worse than. So those people can come out even worse than they were originally. So this is the warning for those drugs, and there's been lots of work going on, how to avoid that. But some centers like Johns Hopkins, for example, are not admitting ApoE44 at this time because of the high risk to those patients. So with that in mind, I think, you having all the information, you can make an informed decision. So I think we're for the first time, as humanity, we're addressing this with the brain more seriously. And there are coming many, as always, when you open the door and start really exploring this and going deeper, then lots of different options starts to appear. And I think we're just in the beginning of what is happening here is quite a revolution. So we've gone in a very few years from for not being able to do anything to being able to really help many people.
Diagnosing earlier and earlier, and perhaps some medical interventions that can make a difference in a subpopulation, and then we have the Bredesen protocol, and I think that Bredesen has already reported. I know they haven't published on it yet, but they've got an ongoing trial that people can access at clinicaltrials.gov, and they're measuring all three of your markers, and they're seeing favorable turnaround in those markers. Correct?
Yes, they are. Yeah. So there's, I think, and the evidence is likely going to be published sometime later this year, early next year. So
good.
I think it's the conclusion of the trial is late this year. I think it's it's a larger trial than he did last time. It's they have this much more powerful biomarkers than any other such trial has had. And in our case, we have done a very, very large validation on these biomarkers, particularly p-tau217. We did a comparison with 1,700 different well-characterized samples. So this first thing you have to do is to measure people that are completely cognitively normal. And we did that with an Australian collaborator. It's called the ABLE Consortium in Australia, and they have a large number of patients that have had PET scans that are normal, and patients are normal and they're cognitively normal. And so with that material, then we can plot the normal curve, and with that in mind, we are then able to be very, very sure of our cutoffs. So when is a person having amyloid and when does not have amyloid? Nobody else in the world has done anything like we have in this regard, and so that's why our assay is really the only one that you can use in the earlier settings of memory problems.
And I want to commend you, because I know that was really difficult in getting those samples, and that it was at great cost financially, and I think just technically, manifesting this body of work that you've done is really pretty revolutionary for the field. So thank you for that.
Yeah, thanks. Yeah, no, it's been very rewarding, I think, and it's nice you could do all the science work you want, and then but then at some point you have to go out there and try your thing. if it's going to really fly or float, if you want. And for us, we did that, and it is, and we get really good response. And we were chosen for the three, I would say, prospective trials with Wake Forest, Michelle Mielke, who was a younger star, full professor at Wake Forest. She was a professor at Mayo Clinic previously. She has one study in the primary care where they compare our test with PET scans, and the first number of tests, I think, the first weeks we were on 100% correlation with the PET scans. So this was something prospective, very hard to correct afterwards. You can't, right? It's ongoing in real time use of your assay. And because we did this very, very large work initially to really get the cutoffs correct and know a lot about our assay, then we were able to provide it in a prospective setting, meaning that in real time, and we have 3 such trials going on with the University of Texas at Austin, and as well as UPMC, which is University of Pittsburgh Medical Center.
How did you then improve on the assay? Like, how did you improve the ability to detect at such, what is it? What is it, like pico? Is it small? What are you measuring it at?
It's not about it's just the same picogram per milliliter kind of thing, but the improvement is really in the antibodies. So the antibodies that we use are better. It's always like that. The humans, first you come out with something, it's amazing, but then you realize that even that amazing result can also be improved on. And I can take the resemblance of troponin, for example. When troponin came out, now the guy was from Germany, and he was ridiculed for many years, but eventually troponin came through, and it's the blood test that is so useful when people come in and say, I have a heart attack. You get troponin drawn in the hospital, and then they observe you, and then you get another troponin drawn, and if both of them are negative, they send you home, and there's nobody almost that die from heart attack at home, which was used to be very, very common. They send the wrong patients home in the old days. So troponin has been revolutionary, and today we're on the 6th iteration of troponin, right? So in the same way, we're going to probably be on many iterations of p-tau 217, because it's one of those amazing assays that come around, though very, very seldom, probably every 20 years, as it's so accurate. And I think last time that this happened was actually troponin, which happened about 25 years ago.
But the legacy labs are just, they developed their own technology, and it's less sensitive, and it's really, other than later stage, it's not going to be useful.
Yeah, they don't really show much passion behind this or knowledge, or
right.
It's a bit surprising to me that they didn't put more effort, honestly. But they have the distribution, and obviously the practitioners that want to use us they have to work a little bit harder. Our assays are a bit more expensive, things like that. But it's going to be worth it. If you want to take the test, you might as well take the best test. Yeah.
Are you guys getting insurance coverage? I mean, where are you at on that journey?
Yeah, I think we're probably getting that in 2025. Yes.
All right, so talk to me about the different p-taus. I mean, if you go into the literature, you see that p-tau 181 is being used. Why 217? I mean, how do we think about the different p-tau proteins?
Yeah, that's a good question. We don't know really why they're just phosphorylated on certain sites of the tau protein, but p-tau 181 is much more abundant. It was the original blood-based assay that came in 2020, first time. There was a really good assay. It was kind of, actually the first work was done by Michel Mielke, the person I mentioned earlier, already back in 2017, but a really good assay came in 2020. However, it was already at that time known that 217 probably has a better signal to noise ratio than 181. So the experience with 181 was more comprehensive. But 217 has emerged as because it's better signal to noise ratio, we're more certain that we are measuring the right thing and that we're identifying right patients. However, with the 217, that it is difficult to measure it, and there's only a few instruments that can do it properly. And so we have many specialized equipment in our lab that can measure this. And we have the instrument that is used by the legacy labs as well, and we have that assay as well. So if anybody wants that, we can offer that at a
Interesting.
much cheaper price than them. So it's we're not necessarily talking against that assay, but we're just saying that if you want the best, then especially early on in disease, you should definitely ask for the ALZpath is the current market standard. And we have a new paper just describing how good that assay is. In that paper, we used neuropathology samples. So neuropathology is the ultimate gold standard for measuring this amyloid pathology. And in that, we found that the ALZpath assay was far more sensitive actually than the Lumipulse assay, which is the assay that the other labs have chosen as their main assay. We have chosen the ALZpath assay as our main assay, but we're also able to report the Lumipulse assay. If people want us to measure it through that assay, we can do it as well.
You've likely heard about the longevity benefits of peptides. They're in skincare, supplements, they're everywhere. But not all peptides are created equal. Developed by skin longevity scientists, OS1, which is found in OneSkin topical supplements, penetrates deeper layers of the skin, impacting cellular level biomarkers for visible improvements in lines, wrinkles, and thinning skin. Ready to experience OS1's benefits? Use code Dr. Kara for 15% off your first order at oneskin.co/DRKARA.
Is there a gap in your health and longevity strategy? MitoQ mitoquinol is an advanced antioxidant that targets the inner mitochondrial membrane, reducing reactive oxygen species by 48%. This patented compound is backed by 30 years of research and 25 clinical trials by Harvard, Yale, and Oxford. MitoQ supports mitochondrial and cardiovascular health, metabolism, and DNA stability. Learn more at mitoq.com/Dr. Kara. That's mitoq.com/Dr. Kara. Qualia's science team is tackling some of the most challenging aspects of health and wellness we all face, from human longevity to optimizing mental health. Their product design is creative, which doesn't surprise me because it's coming from Dr. Greg Kelly, who's widely regarded as one of the brightest minds in functional and naturopathic medicine. You can check out their full lineup by visiting www.qualialife.com/Kara15 and use the code Kara15 for 15% off your order. Okay. And then just for anybody who's familiar with some of these biomarkers, Quest has a plasma beta 4240 that I know you're not a fan of. Can you just speak to what that is, just briefly, because we've got other stuff to cover, but just in case it's on anybody's mind.
No, that's a good idea. Yeah. So A beta 4240 was the FDA approved assay in CSF, so that's spinal fluid, and it's a really good assay in spinal fluid. However, it does not work in blood because there's peripheral production. What that means is that the body makes so in this case the A beta 42 decreases. So it decreases. It's not a normal biomarker where the biomarker goes up, which is also the case of p-tau 217 and 181. Those go up, but this biomarker decrease. But at the same time, you have the body producing A-beta-42 outside, and then if you measure it in the bloodstream, this is confounding then the results.
Sure.
So what we have there is we have a very small, very, very, very small difference, less than 10%, between pathology and non-pathology, which is within their margin. So essentially, if you get a positive result there, it might as well be something that is completely normal. So therefore,
So it could be just in peripheral.
Yeah. So
data.
they have Fitzgerald has decided that the FDA approved assay should be p-tau 217 through A-beta-42. While we like the Fitzgerald assay for mild dementia, as I mentioned, we don't like it so much for MCI, but we like it for mild dementia. We do not necessarily concur with A-beta-42 being in the mix because it just increased the uncertainty. But that's more of a statistical analysis discussion, so I don't think it's something we run into here. But in general, I would say that the p-tau 217 is a very, very strong biomarker and be used by itself. There's no need for other biomarkers if you want to detect amyloid. There are other proteins in the brain that can misfold that are important to detect, and we don't have necessarily the right methods yet developed. But in the future, we will be able to detect many different proteins, even through blood, particularly through CSF.
Just name one that's coming down the pike in blood that you've got your eyes on.
Yeah. In blood, we have something called the BD tau, which is the total tau that is developed in the brain. So brain-derived tau. So that protein can be useful to measure in stroke, in rapidly progressive dementias, such as Creutzfeldt-Jakob, very sinister things. So this is a protein that can give differentiation. So if you measure p-tau 217 and you measure BD tau, brain-derived tau, at the same time, if they're both elevated, then it points to amyloid disease. If p-tau 217 is normal and BD tau is elevated, then it points to something else. So it gives you a signal that something else is going on, and probably something that is quite a bit more sinister than just amyloid. So
okay. And when will that be available? But go ahead.
It will be available in 2025 also. And then we're developing other biomarkers. We have a new biomarker in CSF, so in spinal fluid, that's called MTBR, or tau 243. So this is a biomarker that is already in the protocol, actually, from Alzheimer's Association and the NIH and NIA, which is National Institute of Aging, for detecting in neurodegeneration, and that measures tau that relates to Alzheimer's. So in Alzheimer's, it's a dual proteinopathy. First, you will see amyloid formation, and then that eventually triggers tau pathology, a certain kind of tau pathology. And this biomarker is supposedly, although it's early days, able to detect that tau pathology. So,
okay. All right.
So that's one of the hot biomarkers. But I think there's nothing in the pipe like p-tau 217 that's just a home run for us as a medical community to be the first time ever to have such an accurate blood test.
Yeah. And for just everybody who's listening, clinicians, information about the lab, the papers that have been referenced thus far, all of that will be docked over there. And also just, for regular people or people who want to get this on this suite of testing that we're talking about, we'll put information on the show notes for you as well. All right. So when do we want to start doing this? When do we want to get a p-tau? And, if it's within normal limits, like if we have ApoE4 or ApoE44, if we're, hetero or homozygous, like what's the frequency that we're going to be looking at this? What age do we start at? And then if, we're ApoE33, same question. Like how do we use this clinically in a prevention context?
No, it's a great question. I think it's up to everybody to decide, right? So we have now the possibility to detect this early and perhaps really early is what we're seeing. And I now have been sitting here promising that we're going to have something really, really good in this year. We have something that is already very good, but we're going to have something even much better. No, obviously, as you bend bend up the eye, you can put in and say, okay, now I can start seeing things that maybe it's too much information for some people, right? And that they're walking around with this amyloid in their brain and they feel fine. That maybe is something that makes people depressed or it's not something that they want to know. So I think it's up to everybody, but I would say it's like detecting cancer in stage 1 or stage 0. Wouldn't you like to detect cancer in stage 1 or stage 0? That the answer to that question is probably yes for lots of people, but not for everybody. I mean, I know people that worked with with clinical chemistry their whole life, and didn't take the tests that indicate prostate cancer, for example. Like, there could be all kind of reasons that people just avoid taking a test, and I'm not here to judge that. So I think it becomes a very personal question, but this is starting to be available. So for those that are curious, that are interested to be proactive, this is who we are turning to, and others that don't want that or for other reasons are not interested, that's fine as well. So.
Yeah, I think that's fair. What age do we want to look at this? Like if we're 4 let's say, or 4 with a family history, and we have the guts to go in and look.
4, I would probably start at 50.
Okay.
So there are earlier dementias such as presenilin and stuff such, but those are developing already in their 20s. There are other types of dementias also, or can be related to microorganisms that can develop earlier. And they're overlapping with other diseases such as ALS and such. So there are other where it's earlier, but it's quite evident, right? But for somebody who's cognitively normal and has ApoE44, I would start at 50, personally. Yeah.
And what about 3, say, with family history or no family history?
Yeah. So personally, I have 3 and I have some family history, so I measure myself. Yeah, that's me. But I would say that nobody knows what, and it's again depends on anybody. Anybody's
how
preference.
Frequently? Would this be an annual? I mean, I know it depends again if it depends on history.
Yeah, that's right. So I think
genetics.
Annual is probably fine for some people, but every 2 years is also fine, I think, for some other people. Depends if it was elevated or was completely normal. So we have we have 2 cutoffs. So we have a cutoff that shows that if you're in that first category where it's very low risk, then you can certainly wait 2 years. Nothing will happen in the 2 years, right? Or it will take 2 years before anything happens. And then you have an intermediate cutoff there. I would suggest that you come back in 6 months. So then your intermediate risk, about 50% of those are actually positives, but we are very careful to name who is positive and negative at this time. So we have an intermediate zone. And then we have a high zone with a high risk. And those are actually positives. They are very, very highly likely, with over 95% certainty that they have the amyloid pathology, and they should go on to do something about it. And that, as I mentioned, there are many paths now to help yourself. Even in the study with Michelle Mielke, which is NIH funded, we have lifestyle changes for the MCI.
Oh, you do? Okay, good.
For MCI,
good.
yes. So
all right. Well, we'll link to that study. Yeah.
Yeah. So it's not all. Yes, Bredesen started this to the knowledge about what we could do and changes in our lifestyle and other things, and his ways are very comprehensive. But it's seeping into mainstream as well now at this time. So
fortunately,
it's good to know that there are some people that are not happy mentioning Dale Bredesen, but there's I think lots of people that are starting to acknowledge that he was onto something also. So.
Yeah, it's extraordinary work, and a colleague and friend of mine, Heather Sanderson, has published another trial using his intervention with good outcome in MoCA scores and other cognitive measures, which is exciting. But I know she didn't use your assays, although I believe that will happen in the future. Final question on p-tau, then I want to talk about the other two. Follow-up, so you're doing an intervention, you're following the Bredesen protocol, you're doing it really, really carefully, or you've decided to go the drug route, or you're doing a combination, whatever. How early can you actually see a shift in p-tau?
Yeah, that's a good question. I think 3 to 6 months.
3 to 6 months. So pretty quick.
Depends how aggressive you are and if you're following all the ways. And for that matter, we can also use the new assay that we'll have launched sometime mid-year in 2025. Even the ALZpath assay is able to measure that decrease to some degree, but with the new assay, because of the range is going to be much, much bigger, we're going to we'll be able to see even more of that change. And we're quite excited for this new assay just because of that. So not only can we detect very, very early pathologies, but the change, the treatment effect, we're going to be able to measure in a much more accurate manner, I think, using this new second generation assay.
So p-tau 217 is really quite specific for Alzheimer's.
Yeah.
But then we get to GFAP and neurofilament light. GFAP, again, glial fibrillary acidic protein. I mean, and these guys they really open the door. So they might track with Alzheimer's pathology, but you can see them in traumatic brain injury, in long COVID, as you mentioned, in neuro-Lyme, neuroborreliosis. You can see it in probably, I think MS, if I didn't just say that, but you can see.
Yeah, that's correct. Yeah.
You can see these, just maybe an acute inflammatory, beyond COVID, other viral illnesses. So these guys really expand the utility of these analytes beyond, solely zeroing in on Alzheimer's. So talk about that.
Yeah, so they are, I think GFAP is the quick cousin of Nf-L, so to speak. So if you want to be more aggressive, so Nf-L came quite a few years ago, more than 10 years ago, and was first developed in Sweden. GFAP is a more recent development. Just a few years ago, it's particularly developed with the work of Charlotte Teunissen in Amsterdam. And it's initially it was thought that we're going to be using it for Alzheimer's, but that's now been discarded, and instead it's been thought that it is important to measure it in a number of different cases and can be used as the uptick is very quick versus NFL. It takes a long time before we start seeing the uptick. So in, for example, brain injury, then we see the uptick in just 3 days. It peaks out with GFAP, while NFL peaks out at day 6 or something like that.
What kind of injury? What kind of brain injury? Like
traumatic brain injury, or even other types of brain injuries. But then there are lots of different uses of GFAP that extends beyond that, particularly inflammatory situations where GFAP alone is rising quickly. And then we had this publication out of China early last year where they looked at a huge number of proteins and identified GFAP as perhaps one of the best early detection proteins for all type of dementia. So there are many types of dementia out there. So there's, the amyloid type, which then leads to Alzheimer's. That's around 60% of all dementias where amyloid plays a role. But of all the Alzheimer's, 50% are pure amyloid and 50% are mixed pathologies. So if you take the pure amyloid of all dementias, it's about 30%. And then another 30% is mixed pathologies. And then around almost 40% have other types of pathologies, and that can be a whole host of different things. FTD is one where a certain type of tau pathology that leads to very sinister disease, what Bruce Willis has. I think he became the poster person for that. It's a horrid disease with personality changes and something that very, very sad. So and we don't know much how to interfere with those type of dementia yet. Then you have other types of dementia yet. You have TDP-43, you have, which is related to ALS. So ALS patients, many have dementia as well. And then you have synuclein related, which leads to Parkinson, but Parkinson also get dementia. Then you have vascular dementia, which often overlaps with some other proteins as well. And that can also be a pure dementia, the vascular dementia. So there are.
And you'll see GFAP in all of these presentations.
Supposedly, yes, according to that publication, this is early work, and as I said, it's not been validated further. But it was a very, very large study from China where they used an enormous amount of samples and different proteins, and it was all out of UK. They collaborated with the UK Biobank.
Is this useful as something that we want to incorporate into our annual screenings?
I think so, for the people that are more ambitious, yeah. So I think, as we mentioned, p-tau, it's a yes or no answer. Well, GFAP it can open Pandora's box more, and can be more difficult to actually get something out of. So let's picture a situation where you have a patient that is then normal on p-tau 217, normal on Nf-L, but has a high GFAP. Are you supposed to be concerned? The answer is yes, probably. You should go for a fishing trip to see what is going on. Do we have all the tools to get to the final conclusion? I would say that sometimes we do, sometimes we don't, right? So with that in mind, again, I think it's a personal decision. Do I want to use everything that is available to me? But I also have to understand that if I get a positive GFAP, and it's possible we don't find any reason for it, how can I then manage that? Well, there are lifestyle changes to address that and look deeper, do you have infections? Do you have chronic infections? Do you have mold in your house? Do you have heavy metals? There are lots of things that may be giving problems for you, and this could be an early indication. So so then you go back and look at all these things, and everything comes out fine. Then, all right, then you go and do the best you can in your lifestyle, and then you measure it again, and hopefully that was just a blip on the screen, and everything comes back to normal, right? And it suits some people to do use GFAP that way, and some people don't like to be worried about it. So it's really a personal decision.
What about, so I hear you, that makes sense. I mean, and it could be, maybe they moved through COVID recently. I mean, you could cast a really wide net, I would imagine, with, speculating. If somebody has a really high GFAP, are they likely to have symptoms or not necessarily? Like this individual we're talking about probably doesn't.
Not necessarily. So so we have seen cases where GFAP alone is elevated, and I see that people are not 100% comfortable with that. At the same time, there are people that say, "Oh, wow, that's a new chance for me to address this and go deeper." And if everything looks fine, then make all the other tests that I mentioned, and you're probably going to be okay. You just have to try to live as good as you can, and then eventually it's going to resolve. At least that is my belief. But again, we're very, very new to this biomarker. So for GFAP, for example, I just want to go back to the lab. We did not have a good assay previously, so we were the first lab in the world to set up a good GFAP assay, and that is a quite recent occurrence. So we just have had it available for 6 months or 7 months or so. So it's previous to that, there was an assay that wasn't dependable, wasn't robust, and so whatever we measured at that time wasn't really correct. Now with that we have a good assay, we are exploring novel territory. It's just what happens, right? And
what about inflammation? I mean, you guys are going to I was talking to your medical liaison, Mike, who said that you're going to have age-associated reference ranges super soon, very soon, for GFAP. And, inflammation is a phenomena that increases with aging, which has to have something to do with the reference range changes. And I mean, it seems to me this could be another useful reason to get in there and to engage in lifestyle interventions. I mean, it's my, it's like my area focus. It's my bias that we have some say over how well we age. And it seems like it might be a useful tool there. Do you have thoughts on that?
Yeah, I think so. I mean, I think, we often think that we can abuse ourselves. What we forget is that the body can take more abuse than the brain. So, we come out with a short stick and with the brain, and people think, oh, it's so cool to do this and that, but it's at the end of, if you don't sleep, if you travel all the time, if let alone drink alcohol and smoke, which I'm thinking not many people do on this podcast, but even other habits such as looking at your iPhone at 10 p.m. and not sleeping well and all that is going to get to you and the brain, and right. So I think we have to be careful with the brain. It's still the very, very important organ and tool for us.
Yeah, that's right. I think I could see these assays being, as you said earlier, really scary for certain individuals, but also very, they have the potential to be incredibly motivating. I mean, laboratory data is powerful.
Yeah, it's
to
a
your
whole
point,
new world. It's a whole new world.
Yeah, just being able to identify these changes early. All right, so let's talk about neurofilament light. I mean, gosh, not that I've had the opportunity to be an astronaut, but I might I can't say that I would be excited with an elevated, to go on to live with an elevated neurofilament light. So this is similar to GMAP. So talk to me about this protein, but I'm also, I guess I'm curious since you brought the astronauts up.
So GFAP is more brain specific. It's related to inflammation, can be related to other things going on in the brain also. It's not only inflammation. It's not highly specific for inflammation, but it is quite specific. The NFL is more like, really nerve damage anywhere in the body. So you can get increased NFL if you have nerve damage in your leg. You can get increased inflammation and NFL if you have a brain injury, obviously. So NFL is more like any nerve that gets damaged, and neurofilament light is released, and the assay picks that up. This is an assay that has been around for quite a few years, as I mentioned, probably 10 years. We have really good assays for more than 10 years. The utility of that assay is multifold, and it's used in some centers a lot, in some centers not so much. But it's not specific for anything. It's just specific. It's kind of they say it's troponin of the brain, but I feel that it's more. Troponin is still fairly specific. NFL is less so. So I think it's more like CRP, in infection or something. You can just say that something was damaged, something is there, but it's very general, and it can be, as I said, it can be quite a few different things. But if NFL is increased, then this is something that really draws our attention.
What was the clinical outcome of the astronauts? Like, what kind of symptoms did they experience post-flight? I know you don't want to talk about it, but I keep.
They're not as good as they were before. So they're
not as cognitively sharp.
Yeah. Well, everybody has different reserves, right? So I think it's quite a bit of variability there, and depending how long they were out in space. I don't imagine that the trips that Bezos and company do, and those kind of shorter trips in the near atmosphere are very harmful. But definitely going to Mars or going to the space station or longer trips like that, they are quite damaging.
What's the mechanism that prompts the damage?
We don't know. I think that it's just this environment that the humans were not built for. So yeah.
Yeah. Right. Can we change neurofilament light? Like, if we get it, can we do lifestyle interventions and actually improve upon it like we can the others?
Yeah, to some degree. I think that it's like if you have a traumatic brain injury, depending on how severe it is. Can you reverse that? Yes, depends on so many things. If you're a young child, and most children that have a traumatic brain injury are able to do quite well in life, not 100%, but maybe 90%. Right? As older that we are, the more it's going to affect us. The harder it is to heal the brain. So the question is, that's depends on severity, depends on many things. What we do see is that that doesn't go back to baseline necessarily.
Just we're kind of coming to the end, but I just wanted to circle back to the fact that you see these markers track with clinical presentation. You've seen them track with imaging as well, both diagnosing a condition, but also as we can see some improvement. I think Bredesen is working on that, tracking these markers alongside.
Yes. Correct.
I think he's doing MRIs. I think he might be using BrainKey.
MRIs, yeah. Okay. MRI is useful to again rule out that there's other proteinopathies going on. So if a person has a very the brain is starting to shrink, that is, either very late stage Alzheimer's or it is some other more sinister proteinopathy. So, or you can also see the vascular dementias on the MRI. So MRI is good to rule out other things. But if the brain looks kind of normal on an MRI and the p-tau217 is elevated, then it's even higher chance that you have Alzheimer's.
Well, Dr. Frykman, I just want to say it was great, spending this last hour with you talking about these proteins. What incredible work you're doing, and just really moving the needle on our ability to detect and, therefore develop effective therapies in, the different dementias, but also, beyond that, different neuropathologies. So, thanks for spending time with me. And I just want to ask if there's anything we missed here.
No,
anything that you need to
Cara.
add.
Yeah, thanks, Cara. Thanks for having me on. And it really was a pleasure, and, great questions. So I think anybody who has questions, I would like to encourage them to email me. I put my personal email address, and I'll try to get to responding to as many as possible.
Good.
I'm not sure how many people are on the podcast here, but this is obviously it's new things. I don't have answers to all the questions. We are, dwelling into a new universe in a way, which is a fascinating universe for us that work in it. At the same time, it's important that to get this right, I think, and to look after your brain, obviously, and. In the case of amyloid, I want to say that there's lots of opportunities now to take care of that or to help yourself, both preventive methods as well as ways to address it, either by these protocols by Dale Bredesen or by other functional neurologists or by pharmaceutical agents or whatever suits you. So don't hesitate to get this checked out. I think that is important to mention, that we're moving into a whole new era, right? We're still early days, but we're moving into a new whole era that is very, very positive for human.
I think that's right. It's a real extraordinary time to be practicing medicine, to be in, medical sciences and in the practice of medicine. Yeah, there's more hope than when I first started my career. All right, Doctor, everything will be over on the show notes, folks. The citations, if Dr. Frykman's contact information, all of the information about the lab. So just head over to the show notes. And again, thanks so much.
Thank you. Thanks, guys.
As always, thank you for listening to New Frontiers in Functional Medicine, where our sponsors help bring you the very best minds on functional medicine. These are brands that I know, I trust, I use in clinical practice, and I can confidently recommend to you. Thanks to our Diamond Level sponsors. For over 40 years, the foundation of biotics research has been innovation and quality. Their goals remain unchanged: innovative ideas, carefully researched concepts, and product development with advanced analytical and manufacturing techniques. Biotics nutritional products are of superior quality and effectiveness. They are available exclusively to the healthcare provider. Find them at bioticsresearch.com. Precision Analytical, creator of the Dutch test, is launching a new educational program this January. They are offering evidence-based training on key topics like hormone metabolism, interpreting Dutch test results, and therapeutic strategies, including hormone replacement therapy, all aimed at improving patient outcomes. Become a registered provider to gain access to an expansive education hub with ongoing content, including webinars and case studies. Visit dutchtest.com/courses to get started and grow your practice. Thanks to our gold level sponsors. Timeline, fueling cellular energy for a lifetime of healthy aging. Find them at timeline.com. Vibrant Wellness, transformative lab tests for wellness. Find them at vibrant-wellness.com. Disclaimer. This podcast is for informational purposes only. If you have a specific medical concern or if you have any questions, please speak with your healthcare provider.